We're glad you're all here with us today. We are going to be playing a game show, and I believe we did this last year, called 3 Truths and a Lie. And your mission is to identify the incorrect statement. So we're going to bring up 8 polls for you to answer, and each poll will have 4 statements. And you can utilize a QR link, which we will bring up shortly, to select the inaccurate, incorrect statement. We'll be reviewing some general guidelines, teaching position, E&Ms, modifier 25. I think since the audience is pretty big, we would recommend using the chat functionality if you have questions, and both Lucy and I will keep an eye on that as we move through the presentation. And with that being said, I think I've covered all the logistics. We will go ahead and get started with the first poll. But before we do that, we actually need the QR code. So you're going to scan the QR code with your phone. I'm sure everyone is aware of this. And it will bring up the actual poll with the 4 responses. You don't need to sign up for anything. You can bypass any of those prompts that come up. So we'll leave this up for a minute, and we'll bring it up periodically throughout the training to ensure that everyone is playing. I mean, this is certainly, we'll go by quicker with the interaction. Thank you, Amanda. So we'll get started with the first poll. So first poll is regarding teaching position guidance. Which statement is incorrect in regards to TP rules? 1, generic teaching position attestations to a resident's E&M note are not acceptable when working with a resident. 2, generic TP attestations to a resident diagnostic interpretation are not acceptable. 3, for procedures completed by the resident that take less than 5 minutes, the teaching physician must document their presence for the entire procedure. And for procedures that take longer than 5 minutes, if the resident completes, the teaching physician needs to identify the key portions and document their presence for those key portions.
It looks like the majority, everyone got it right. So this is the only circumstance where a generic teaching physician attestation would be acceptable. If a resident prepares and signs the interpretation, the teaching physician must indicate that he or she has personally reviewed the image and the resident's interpretation and either agrees with it or edits the findings. When that occurs, your attestation could be as simple as I have personally reviewed the images and dictated or reviewed or edited the final report and agree with the findings. For evaluation and evaluation management services, when working with a resident or a fellow, your documentation needs to support that you saw the patient, evaluated the patient, and participated in the plan. An attestation that reads, patient was seen and examined with the resident, the note was reviewed, and I am in full agreement is considered a generic attestation. It lacks your personalized participation in the plan and is not acceptable. At Yale Medicine, the residents and fellows cannot document a teaching physician attestation or presence. For minor procedures, those are typically less than 5 minutes. The teaching physician must be present for the entire procedure. And for major procedures, typically greater than 5 minutes, a TP must be present for the key portions. Teaching physician rules do not apply to APPs. APPs cannot attest to a resident or fellow note. They cannot attest to an APP student note or a medical student note.
Okay, we'll move on to the next poll. Which statement is incorrect in regards to medical students? The medical student does not have to perform the history of present illness, exam, and plan in the physical presence of the TP in order to support a billable service. If the teaching physician is physically present with the medical student, the TP must still personally perform or re-perform the physical exam and the medical decision-making in order to bill. 3, the medical student policy only applies to E&M services. This does not apply to diagnostic services or procedures or surgery. And 4, APRN, PA, certified nurse, midwife, audiology, speech, or any other type of student is not considered a medical student for purposes of billing. So we're looking for the inaccurate statement when working with a medical student. And I know not every practice works directly with medical students. It's been my experience that students work with residents and fellows. this may not come easily to everyone. Okay, I think we're moving in the right direction.
Mhm.
So I think we can move to the next slide, Amanda. That gives the incorrect answer, and the majority of folks have gotten that correct.
So the first one is incorrect. Medical students must perform any billable service in the presence of the teaching physician. The teaching physician must personally perform or re-perform the exam and medical decision-making, but does not need to redocument if the medical student note is accurate. This guidance is specific to medical students only and evaluation and management services. It does not apply to procedures or surgeries.
So our third poll, again, which statement is incorrect? And this one is related to evaluation and management services. First, a new patient has not seen the MD or APP of the same specialty in the last 3 years. For outpatient E&Ms, the attending's total time on the day of the encounter or medical decision-making can be used to determine the level of service. The rule when over 50% of the visit was spent counseling the patients applies to inpatient consults and observation E&Ms for billing in 2023. And 4, the documentation for a consultation requires the requester's name, reason for consult, recommendations, and a written report. So we're looking for the inaccurate statement as of 2023. Might be helpful.
Here we go.
But everyone seems to be on the right track here. So if we go to the next slide, you're absolutely correct. The good news for 2023 is that the same guidance that applied to outpatient for 2021 and 2022 has been carried over for all evaluation and management services. Okay, so I'm getting some messages that it takes a little while to read each statement since there's different topics. So yes, we can absolutely slow down. And there's also a question in the chat about consultations. I'm aware of one commercial carrier that still accepts consultations, and Medicaid does as well. So with that being said, if we bump to the next slide, if you're rendering, providing a consultation, we recommend billing for the consultations. The Epic crosswalk in the background will convert the code based on the insurer. So when billing a consultation, your documentation needs to support that you were asked to see the patient and consult, the reason for that, and your recommendations. And in the ambulatory setting, that does require a report being sent back. Again, the good news for 2023 is history and exam no longer play a role when selecting your level of service for an E&M, but you certainly want to ensure that you're documenting any history and exam that's medically necessary. So that is great news. The same guidance that we've been talking about in the last 2 years, medical decision-making or the total time spent on the day of the encounter can be utilized when selecting your level of service. And if we move through the next set of slides, we have offered some additional information on medical decision-making. I'm sure this looks very familiar to everyone. Is made up of 3 criteria. The first is the number of complexity of problems addressed. 2 is the amount and complexity of data reviewed and analyzed. And 3 is the risk. So if we move to the next slide, when selecting your medical decision-making, you need to meet the requirements in 2 out of 3. I apologize, these E&M cards look extremely grainy in our presentation, but we just wanted to make you aware that they are available electronically, and we are waiting on additional laminated copies. We're happy to send it to all of the participants after this training. So these cards are available for outpatient, and in this case, this is an outpatient code. It includes 99202, 12 down to 99205 and 15. The 3 categories of medical decision-making are up at the top, and you need to meet 2 out of those 3. The second part of the card, if we click to the next slide, speaks to time, and this should look familiar. Nothing has changed for time in 2023. Offers the time, so you can bill based on total time spent on the day of the encounter. and specifically for the day of the encounter. So you cannot bill for any time spent the night before or the next day. I see a question in the chat. Provider has to be physically present to see the patient for a hospital consult. Absolutely, yes. If you're billing a hospital consultation E&M service, you need to be present with the patient, yes. And within the body of this E&M card, there are the teaching physician rules. So whenever you're billing an evaluation and management service based on time, you as the teaching physician need to bill for your own time. You cannot bill for any time spent by the resident where you are not also present. So we're going to click to the next slide, which is basically the same card, but for inpatient and observation, 99221, 99231, all the way down to the highest levels. And then the second part of that card also speaks to time. So again, having the electronic copies will be a lot clearer. And then if we move to the next slide, Amanda, this brings up the times associated with the inpatient criteria. Since you can bill based on total time spent on the day of the encounter. First set of codes are your initial hospital codes and your subsequent hospital codes, observation codes, and discharge codes. The CPT book has combined inpatient and observation criteria, so it is similar based on the levels. And I think the next couple of slides will help clear up the actual criteria. So we broke this down into 3 slides. Since the same criteria covers all code sets, outpatient, inpatient, outpatient consult, inpatient or inpatient consult, and emergency room, we've combined it into one medical decision-making grid. The only exception is ED codes do not have an associated time, so you cannot bill them based on total time. But quickly, medical decision-making is based on 2 out of these 3 elements. So if you wish to select a level, it needs to meet the requirements in 2 out of the 3 components. If we move on to the next slide, these are our additional levels, our level 4s, our level 5s for outpatient and consultations, our level 2s, and our level 3s for inpatient services. I do want to point out that if we can go back one slide, I apologize, Amanda, there were some changes under the level 3 outpatient under low medical decision-making, and this is the category that was added, very difficult to see, and I apologize. 1 acute uncomplicated illness or injury requiring hospital, inpatient, or observation level of care. So if you're thinking of hospitalizing somebody because of an uncomplicated illness or an injury, that would fall under a level 3. And the other change to the medical decision-making grid is included for level 5s. And if you bounce to the next slide again, under high risk, there have been some additional categories added. So that would apply to your outpatient level 5s and your highest level of inpatient services. So parental controlled substances, if you're managing a patient on parental controlled substances, that would fall under high risk. And a decision to hospitalize a patient or escalation of hospital care would also count under high risk. So again, I think the cards are most helpful. And I see that there's some questions that are coming up in the chat.
So
if you see a patient, go ahead, Liz.
Yep, if you see the patient on days after the inpatient consult, can each day visit be billed? And yes, they answered it correctly. It's for subsequent hospital care codes, CPT 99231 through 99233.
Of course, and that would be based on medical necessity. So if your medical necessity is the overarching criteria for any evaluation and management service. So if you perform a consult and you continue to care for the patient, you can bill subsequent hospital services. So if we click to the next slide, Amanda. These are our level 4s. Next, oh, I'm sorry, stop there. I'm sorry, go back. I apologize. It's early on a Friday morning. So we pulled out the level 4 outpatient, 99204, 99214, the level 2 inpatient, level 4 consult, just so that you can get a clearer picture. So this criteria has not changed for level 4. So if you're seeing a patient that has a chronic illness with an exacerbation, you could select level 4 moderate under problems here, or an acute illness with systemic symptoms, And if you're also managing that patient on prescription drug management, you've already met the 2 out of the 3 criteria. I also wanted to bring to your attention that diagnosis or treatment significantly limited by social determinants of health falls under moderate risk as well. So if you're seeing a patient with a chronic illness with an exacerbation, and you've clearly documented significant social determinants that are barriers to healthcare for this particular patient in the progress note, you could fall under a 4 based on that. I also wanted to take a look at this second column, which speaks to data, which has changed significantly over the years. So in order to achieve moderate under data, you have 3 categories in which you can document. The first category is test documents or independent historians. So if you reviewed or ordered 3 separate laboratory tests, a chem panel, a thyroid panel, and a CBC, that would equate to a level 4 under this category. If you offered your own independent interpretation of a diagnostic test, that would fall under this category. And if you documented a discussion of management or test interpretation with another physician, external physician or healthcare provider, that would also fall under another level 4. So this column is a little complex, and I do recommend reading the rules when you're clicking through the calculator and understanding what you're checking off. I don't see any other questions related to that. Just a few more slides related to E&M services. We'll keep clicking through. So again, history and exam no longer play a role, but you should be documenting what's medically necessary. 2 out of the 3 medical decision-making components must be met. We talked about social determinants of health. It needs to be addressed in order to be considered. If you order a unique test, it's counted once, and that includes the review of the results, even when the review is done at a subsequent encounter. And performance and interpretation of a diagnostic test during a patient encounter cannot be counted towards your medical decision-making, since you would be billing separately for that service. You wouldn't count that under your medical decision-making. So we're going to move on to the next slide. I do see a question. So review of outside labs / tests and care everywhere meets this criteria. So if you're bringing in the review of any diagnostic test that you've reviewed, that it could have been done by an outside lab, yes, that would count. Unless it's extremely historical and not pertinent to the visit at hand.
Right, and it's clearly documented.
So a change that occurred related to drug toxicity for 2021. So if you're treating a patient with a drug and you're monitoring for toxicity, you can no longer use symptoms for that monitoring from a billing perspective. Your monitoring needs to be based on diagnostic testing, and it needs to be at least quarterly for long-term. And this speaks to the independent historian qualification. So if a patient is alert and oriented and able to provide their history, we would not consider the wife of a patient who is able to provide their history as an independent historian. An independent, the use of another historian is based on medical necessity. If you're unable to obtain that history from the patient, then it will qualify. When we click to the next slide, I believe there's one more. No, time defined. So these are the qualifications when billing based on time. So you can include any time spent devoted to the patient's care on the day of the encounter, which includes all of this: preparing to see the patient, obtaining and reviewing a history, counseling, documenting, anything that's related to the care on the day of the encounter. And the next slide speaks to times. So here are the outpatient times, haven't changed for this year. And you're only counting the billing provider's time. You cannot count the resident's time and MA's time. It's only your time. And the outpatient times are ranges as opposed to the inpatient times. Oops. You can go to the next slide. Thank you, Amanda.
So we have a question about consults.
In the hospital, when seeing a new consult, should we be using the billing codes for new consults? You should, if you are providing a consultation service, you should be dropping the consultation code Epic system has a crosswalk in the background that will flip the code when necessary if the insurer does not cover consultations. Are there any billing implications for those two different designations? I'm not sure. Those are two separate codes. So again, Medicaid and one of our commercial carriers continues to pay for consultations. So we would expect that we would be billing consultations. So yes, there is a difference in reimbursement
And
in
codes
regards to.
Right, and codes are either, consults are either it's an inpatient consult or it's an office outpatient consult. It's not, consults are not by new or established patients.
Oh, thank you.
Mhm.
And then here's the associated medical decision-making and time for your inpatient code. So up at the top, you have your initial hospital visits, then your subsequent, then your admit and discharge into inpatient observation, and then you have your discharge codes. So the times have changed slightly, and they are not spans. They are just one particular time. We don't see any other questions. So we'll move on. I think there may be another. Okay, so the next topic is shared visits. So this is our fourth poll. Which statement is incorrect in regards to shared visits? 1, the MD must document a substantive portion of an E&M visit in order to bill if an APP is participating in the service. 2, the APP must be a YM employed and leased by YM and fully credentialed with the payers. 3, the MD must document why it was medically necessary for his or her involvement in addition to the APP. And 4, attestations can be used by an MD to support his or her involvement with the APP. So we're looking for the inaccurate statement here.
Okay,
We see a question.
Yep, we see a question.
Go
Just
ahead,
to
Liz.
clarify, the existing rules for billing based on medical decision-making for return and new patients now extends to consults and inpatient care, correct? Yes, that is correct.
That's always been the case, medical decision-making. So the new, just existing rules for billing. Oh, I say for the outpatient world. Absolutely. That's a great way of saying it. The existing rules in place for outpatient for 2021 and 2022 now extend to all E&Ms, which is good news. Finally, some consistency. So
Based
which
on
statement is
MDM or
incorrect?
total time. So it could be based on your medical decision-making or total time.
Hey, I
And we
thought
can
last
send
year,
those-
sorry, just had a quick question. I thought last year for consultation, it still went by the 2021 rules for documentation and then the billing matrix or coding matrix for that. Did that change for this year as well?
Last year, the consultations required a history exam and medical decision-making, the same as inpatient codes.
And it changed for this year.
Correct. Yeah, and I think that's a little tricky since Medicare does not cover consultation codes. And it didn't apply to consultation codes when the 2021 changes took place for outpatient. It didn't apply to consultation codes. It didn't apply to inpatient observation or ED codes. Now in 2023, the AMA has applied the guidance to all codes. And I think sometimes there's confusion when you're billing consultation codes. Should I be billing an initial hospital code or an office outpatient code instead of the consultation code? We recommend dropping the consultation code based on the current criteria, which is medical decision-making or total time spent on the daily encounter. So it was a little confusing last year. I absolutely agree. So we don't have too many participants for this question.
We do have another
But
question.
I do see.
Yeah.
Okay, go ahead, Luce.
So if a patient comes in for a procedure and another test result is reviewed, not ordered by me simultaneously, can a separate E&M code be billed?
That's a very different question. And we're going to cover modifier 25 in that separate E&M in a subsequent slide. So maybe we should hold off on that one.
Right,
We can talk about that.
sure, but that alone would not support an E&M.
Okay. So to get back to shared visits, we don't have too many participants, but the majority are answering the question correctly. So we do not recommend utilizing teaching physician attestations when working with an advanced practice provider. An advanced practice provider is a billable, licensed independent provider. And if they're providing a service and documenting the service, they should be billing for the service. So this is just an overview of shared visit rules. Nothing has changed for 2023. There were significant changes last year, and I just wanted to briefly touch on them. If you're rendering an E&M service with a Yale Medicine advanced practice provider, so keep in mind, shared visit rules only apply to E&M services. They do not apply to procedures, surgery, or any other type of service. And they only apply when both the physician and the advanced practice provider are Yale Medicine employed, leased, and fully credentialed. So you cannot share a visit with an NEMG APP. So that you need to clearly understand who you're working with. So when providing an E&M service, both providers document their contributions, and there's two ways this can occur. You can bill based on total time spent on the day of the encounter, and both providers would document the time spent. You would add the time up, and the provider that spent more than 50% of the time would be the billing provider. If you choose not to bill based on time, the provider that documents the substantive plan would be deemed the billing provider. Documentation needs to be signed by both providers and needs to include their contributions. And when billing a shared visit, you should be applying a modifier FS to the E&M code. So nothing has changed for 2023. There was some discussion last year about not allowing, only utilizing time versus substantive plan in 2023, but that's been squashed. I'm not sure if that will occur next year. So you do have those two options. So in addition to documenting time, medical decision-making, the next slide speaks to the medical necessity requirement. So Medicaid, one of our bigger payers, as well as some of the private insurers, want to understand why it was necessary for the physician to participate in the visit in addition to the APP. So they want to understand why they're paying the higher rate when they can pay the APP for the visit. So it's important to include medical necessity for your participation as a physician when billing a shared E&M service. And this smart phrase, .md APP involvement, will prompt you to document that medical necessity. There's a drop down. So any questions on shared visits? Okay, Lucy, did you want to go back to your response that you had put into the chat regarding the separate procedure, or do you want to save that for the Mod 25 slide?
So let's save that for the Mod 25 slide.
Okay, thank you. Okay, Amanda, we can move on to the next. I don't see any other questions.
I'm going to give you a break from.
Sure, thank you.
Yeah, sure. So which statement is incorrect in regards to cloning? Epic has an audit trail that shows who documented what in every note. Cloning is an acceptable practice. Yale Medicine Practice Standards prohibit the HPI exam and plan from copy forward. Pre-charted information needs to be verified. Please cast your vote.
So remember, we're looking for the inaccurate statement.
Okay, we're on the right track. So
Yeah.
The true definition of cloning where nothing changes is not an acceptable practice at Yale Medicine. Yale practice standards prohibits the use of the copy functionality for the chief complaint, HPI, and exam. This should be newly documented for each visit. Epic has a hover feature. We can see all contributors of the note and in most cases where the information originated. We do not recommend copying information from outside the chart since HIPAA requires an audit trail to be maintained in Epic. All information should be housed in Epic, and any external notes should be scanned and maintained in the media tab. Entries carried forward from a previous visit must be reviewed for accuracy and edited appropriately. Be sure system phrases represent what is happening in today's visit, and clinical data and the clinical data that was not done in today's visit is clearly indicated. It's not appropriate to copy forward information if it's not appropriate or pertinent to the date of service rendered. And we've received a lot of payers requiring the medical decision-making to be met because of all the cloning in EMR.
Well, now that's a given, right? Since the codes require medical decision-making or total time. So that's my biggest concern when I see, the plan is copy forwarded and there's no changes to the plan. Medical necessity will be questioned. So you want to ensure that you're specifically updating that plan, given the fact that medical decision-making is the overarching criteria. Thanks, Lucy.
You're welcome. So question 6. Which statement is incorrect in regards to scribes? A resident can act as a scribe. The MD must affirm he or she personally performed services. The MD must document the note was reviewed. The note was reviewed and is accurate, and the MD must sign the note. Okay, we're on the right track. So the first one is incorrect. A resident cannot act as a scribe. We have not seen residents or APRNs or PAs used as scribe since they actively participate in the care. We have a virtual scribe program here at Yale Medicine, and there's a workflow that has been set up that allows the scribe to pull up the appropriate attestation. You see it here. The program seems to be doing well in most departments. Anything you'd like
Yes.
to say? Yeah.
The only thing I wanted to point out is you can see the scribe attestation. We collaborated with this external contractor regarding the virtual scribe program to ensure that all the required components, including that pre-charted information that may occur when a scribe pre-charts something in the morning. And when we're looking, at charts that involve a scribe, we'll offer any feedback and usually pull the coordinators in, but it seems to be working from a compliance perspective. And I know that they're thinking of moving into other areas outside of ambulatory. So I don't see any questions related to scribes. It's all good news. So this modifier 25.
Yes. Which statement is incorrect when billing an E&M service at the same encounter as a procedure? Your documentation must demonstrate. The first one is the purpose of the E&M was to evaluate a specific complaint, and you append modifier 25. The complaint or problem addressed can stand alone as a billable service. The next one, you performed and documented the extra work that went above and beyond the typical work associated with the procedure code. And the fourth one, you cannot bill an E&M when billing for a procedure during the same encounter.
Again, the inaccurate statement.
Okay.
This is a hot topic.
This is a tough one. We know it's on the OIG work plan. It's on our internal work plan, audit plan, to review services with modifier 25. The fourth one is the inaccurate statement. If a patient is coming in for a procedure, it would be rare, and I put this in the chat, that you would bill an E&M unless you address a significant problem or complaint. Documentation needs to support that there was a significant amount of additional work above and beyond what the physician or APP would normally provide, and when the visit can stand alone. Make sure that modifier 25 is being applied appropriately when there is a significant separately identifiable problem and it's addressed in your plan. Keep in mind, all procedures include pre, intra, and post-op work. If the purpose of the encounter is to perform a pre-scheduled procedure, We would not expect an E&M billed unless some specific complaint was addressed over and above the reason for the procedure. For example, if a patient returns for a scheduled cystoscopy, you spend time explaining the findings to the patient, that is included in the global, and an E&M is not separately reportable. However, if during that encounter you identify a new or worsening problem that is being discussed or evaluated and treated, and there is a plan that is associated with the problem, then an E&M may be appropriate. I guess the key is recognizing the extra work. Your extra work is significant. The next slide goes into a little bit more.
Yeah, it does. It reiterates everything.
So when billing an E&M service along with the procedure, your documentation must clearly demonstrate. I kind of went over these, but the purpose of the E&M was to evaluate a specific complaint. The complaint can stand alone as a billable service. The extra work was performed that went above and beyond. The key components of the appropriate selected E&M service were performed and addressed the presenting complaint. Let's see, I just don't want to know that.
There's a message in the chat, so talking about, a cysto is being done on the same visit. So you're absolutely correct. And I think, what needs to be clearly documented, since evaluation and management services are based on medical decision-making. If your medical decision-making is to perform this cysto, and that's what you're doing, and any follow-up associated with the cysto, a separate E&M wouldn't be supported. But if your plan was significant and included other problems, additional plans, then an E&M may be supported. So you are correct. Writing a separate note isn't always, it's always recommended that your note be separate from the procedure. But again, the components of that significant, separately identifiable evaluation need to be included. The fact that you have two separate notes doesn't always support that. And this has been coming up frequently from coding and billing. We look at quite a few examples after they've inboxed physicians. And as physicians are saying, no, I believe the evaluation is supported, it will generally come back to our team and we'll take a look at it. I think when you're treating a new patient, a separate E&M is often supported unless the procedure is pre-scheduled and predetermined. It's when you get into those subsequent encounters that it can get gray. So I think the new guidance sort of helps me when I'm looking at this. Since medical decision-making is required, it needs to be clear what your plan entails that's over and above this procedure. So thinking of it in that manner may be helpful. This is a focus of the Office of Inspector General, CMS, and since we have a risk-based audit plan, it is one of our focuses. So we look at this on a regular basis. We're about to do another round of audits.
So there's a lot of chat. Let's see what's happening here.
Yeah. So again, what is a bladder tumor is found at a cysto and plans need to make to go to the OR? Yes, that sounds to me like you've got a problem based on this cysto, and then you have a robust plan associated with it. Mm-hmm. It's helpful to have, distinct ICD-10 codes, absolutely. But again, if the evaluation is totally focused on the procedure, and there's nothing significant, outside of that, it's diagnosis code alone would not be helpful or supported. And I think I have a cystoscopy bold-faced with header in the note. It's great to have your notes separated, but again, if the documentation for the E&M does not support a significant separately identifiable E&M over and above the cysto, the E&M still will not be supported. So I think this criteria is very helpful. It comes straight from CMS. Mm-hmm. That's what we go back to when we're reviewing. Lucy and I spend a lot of time looking at notes. Mm-hmm. We realize that there's a lot of subjectivity. So our best advice to you is if that additional evaluation supports a robust plan to include as much detail as possible.
Right. And your thought process, I know documentation could be, it's a thorny subject, but the more you document in this case, the better we understand what your thought process is If you are reviewing lab work, if you're ordering lab work, what are you trying to rule out? Is something worsening? Is there something you're trying to work through? It's helpful, and these can go right out the door when it's clearly documented. It's those that there's blood work ordered and there's no plan or there's nothing left. It just leaves us with many questions.
So all good questions, good feedback in the chat. Thank you for collaborating with that. And you will get an email from Lucy if she's looking at services billed with modifier 25, whether they support or they don't, you'll receive feedback. So we will move on. Can modifier 25 be used with a new patient? Yes, modifier 25 can be used inpatient, outpatient, new patient consults, any E&M service, correct? Yes. So modifier 25 just is telling the payer, I provided an E&M service and a procedure on the same day, and that evaluation and management service is over and above what I would routinely do for that procedure, and it's significant, so pay me for both. So you're sending the claim, when you're dropping an E&M code in a procedure, and you don't put that modifier 25 on, the coder is going to do so because you're dropping both codes. They are not reviewing your documentation to ensure that it supports, although they are doing some QA and bouncing things back. So you need to keep that in mind. So our last poll, 8, relates to federal violations. So which statement is incorrect in regards to federal violations? Violations of the anti-kickback statute can result in prison sentences and fines with penalties up to $50,000 plus 3 times the amount of remuneration. Providers cannot be excluded from the Medicare program. 3, an MD routinely referring patients to an oxygen supply company that he owns is a violation of Stark. And 4, billing for services not rendered or misrepresenting the services billed may violate the False Claims Act. So we're looking for the inaccurate statement. And this is our last poll. And I always hate wrapping up the training with this type of a poll, but I think it's important to be aware of the federal guidelines. And we are definitely moving in the right direction. So yes, providers can be excluded from the Medicare program. And if we click to the next slide, it gets into the details associated with exclusion. So from federal healthcare programs such as Medicare, any fraud or abuse conviction involving a false claim. So the submission of a false claim. If you get our alert newsletter, and you should if you're billing services, we often have a column related to what we've identified as other entities violating False Claims Act, or just for informational purposes. And we often see modifier 25 in this arena. Ophthalmology, ENT, billing, laryngoscopies, the same day as an evaluation and management service. So it is something that's focused on by the federal government. So submission of false claims, in that manner can result in some consequences. Other reasons for exclusion would be related to loss of licensure due to drug and alcohol and failure to pay back student loans. So just to get back to the previous slides, the anti-kickback statute, in most industries, it's appropriate to reward those that send referrals your way. In the medical industry, it is absolutely not appropriate to offer any remuneration for referrals. That is a clear violation of the anti-kickback statute. We've seen examples of this in the past, not here at Yale, of course, orthosurgeons accepting kickbacks from device manufacturers for exclusively using their artificial hips and knees. So those are the types of things that we're looking at. So in addition to the anti-kickback, it spoke a little bit about the Stark law, and there are exceptions to the Stark law in academic medical centers, but basically that example that was provided, if a provider or someone in their immediate family has a financial interest in a medical supply company, such as an oxygen supply company, you shouldn't be self-referring patients to that oxygen supply company. Again, there are many exceptions to this rule, and the best approach would be to reach out to general counsel if there were any specific questions. So I think we've covered the 3 biggies there: anti-kickback, false claim, and Stark. Again, the next slide does speak to our open door policy here at compliance. If you have a concern, we encourage you to bring it to leadership in your department. If you're not getting an appropriate response, you certainly can reach out to us directly. or this hotline is available in those instances for any compliance concern, not just a medical billing compliance concern. It is maintained by an outside contractor. It's a hotline for, compliance issues. You can reach out to them and it gets disseminated to University Audit, and University Audit distributes it to the appropriate individual. So this is just another way in which to do that. But, before that occurs, we do encourage you to reach out to us or someone else in the compliance arena. And so that concludes our training. Any questions before we wrap up? I'm sure that everyone's got patience and
Stuff to do.
yes, and I did receive some feedback in the chat that the photo was not working with the scan, the QR code, and that utilizing the website the link was extremely helpful. So thank you for that feedback. I'll have Amanda take a look at that, and we'll make sure that we bring up both in the future. And we do appreciate your time this morning. If you have any specific questions related to this training, please feel free to reach out to either Lucy or I. We will send the E&M cards, the electronic versions, to the individuals that facilitated, set this training up so that they can distribute it to the group.
And I think
In
it
the
takes,
meantime-
Amanda, I don't know how long, I think it takes a few days before their credit is shown, their NBC credit.
2 weeks.
Yes.
I would say 2 weeks at least. It takes quite some time.
Yes.
Yeah.
Okay.
Thank you for that reminder. But have a wonderful Friday, everyone, and thank you for your participation.
Thank you, everyone.